Excellent. It's 2 minutes after 11:30, and we'll slowly get started to reward those of you who are here on time and the ones that are still connecting. So thank you, everyone. A very good afternoon, and thank you for making this time during your lunch break to join this very important webinar, in our opinion, and definitely the first of its kind that is really bringing together not just clinical anesthesia teams, but also experts from facilities management and environmental health and safety. When we created this webinar and when we sort of conceptualized it, we wanted to bring a multidisciplinary team together and focus not on why we need to deactivate and move towards a height or a point of care delivery system for nitrous oxide, but really how do we do it? And really bring leaders and experts who've led the way nationally, like the Providence health system and the UC system. So thank you all for joining. We're very excited that you're all here. Just a few housekeeping stuff before we get started. This webinar is being recorded, and we will share this recording at different platforms, including the ASA, WFSA, AAMC, and many other platforms, along with the toolkit that we're currently working on as well. So this all will be made available for those who cannot attend and stay towards the end. The other thing is that at the outset, I just want to thank the two young faces you see on here, Michaela White and Kai-Ying Wong, both with the University of California, San Francisco Health System, who've made this webinar possible and who spent countless amount of time doing this webinar in the first place. The last thing is, of course, none of this would be possible without the University of California Health Systems and the Office of the President for supporting this effort. So without much ado, I would like to start sharing my screen, give a very brief overview of why we're here today, and then I'm going to let the panelists take it away. And as we go along, I'm going to introduce our fantastic panel that we brought together today. So I'm going to start sharing my screen. Okay, and is that visible to everyone? Okay, fantastic. So we'll get started. And I wanted to say that as we were picking the topic, I think it's so poignant to have this word collaborative approaches, because I know I heard as a child, my parents would always sort of talk about is, if you want to go fast, go alone. But if you want to go far and if you want to go further, then do it as a part of the team. And I think that deactivating pipe nitrous and many other sustainability efforts have really made me realize that a multidisciplinary approach to this problem and many other problems we face in this area is the way to get it done. And especially for this topic, working with our sort of team members from the facility services, with environmental health and safety services, perioperative directors, or anesthesia techs, all of us together, a multidisciplinary team has really made this possible. No one on this call needs a reminder, but a good refresher that the impacts of pollution are the major cause of human morbidity and mortality, right? We're seeing, temperature rises, asthma seasons, vector-borne diseases impacting almost every single human health system. And among that, US healthcare is an outlier. Healthcare in itself globally contributes to about 4.5 to 5% of global emissions. But the blue dot on the screen is a reminder to all of us that US healthcare system is an outlier. Not only are we the most expensive healthcare system in the world, but we're also the most polluting. Per capita, compared to our high-income peers, US healthcare produces about 8.5 to 9% of all its national emissions, right? And to put this into perspective, if US health system was a country, depending on the year, we would be about the 7th largest emitter of greenhouse gases in the country. And this emissions and the pollution caused by healthcare has a huge impact on human health. You know, the health of the same patients that we sort of swore to take care of. And with that in mind, in 2021, the National Academy of Medicine created an action collaborative. And the action collaborative has a multi-step approach. And you can see one of the steps highlighted here was to reduce emissions from anesthesia gases and reduce emissions from metered dose inhalers. Now, there is no bolder statement, there is no important statement than the one that comes out of National Academy of Medicine, where we as scientists, as educators in higher ed, as researchers, all affirm that this decarbonizing healthcare is one of our goals. And in that, focusing on anesthesia-related emissions is crucial. Right. Now, why were anesthesia gases implicated? And why nitrous oxide in particular? Now, we know anesthesia gases are, potent greenhouse gases. They have a high global warming potential. And this group and many others nationally and globally have focused on the common anesthesia gases like desflurane, sevoflurane. But for the purpose of today, we're going to focus on nitrous oxide, right? And just a reminder for a lot of these in the group is nitrous oxide stays in the atmosphere for more than 100 years. Of all the anesthesia gases on the screen, nitrous oxide is the only one that affects the ozone layer. It has ozone depleting properties. And if you look at its global warming potential at 273 times that of carbon dioxide. Because by definition, the global warming potential of carbon dioxide is 1. So nitrous oxide is 273 times potential of warming than carbon dioxide. So with that in effect, and we've seen that the clinical utility of nitrous oxide is going down, right? For various reasons. We have newer anesthetics. It does cause nausea and vomiting. There's occupational hazards with using nitrous oxide. So while there is a trend in decrease in clinical use, sadly, procurement data across health systems did not match it. And we saw that across different countries and different health systems, right? From Australia to NHS in the UK, Providence health systems saw about anywhere from 40 to 99% leak from the procured nitrous oxide. So did we here at UCSF Health. And actually, Dr. Cheesebro and me have written about it and will attach a link to that in the chat. So we embarked on our journey, again, with a lot of support from the Providence Health System, on really deactivating piped nitrous from our existing facilities. But also currently they have hospitals building without piped nitrous, and value not just in the piping that doesn't need to be installed, the maintenance of the piping, but also decrease from the carbon impacts of the nitrous oxide that's been vented. And I'll let Dr. Cheesebro talk a lot about it afterwards. Right. None of this, as I said, would be possible without the support of the Office of the President, who made this an operational priority across the UC system. And I wanted to share our fiscal year 2023 priority from the Office of the President was decreasing inhaled anesthetics, decreasing nitrous oxide, and also for a lot of the facility leads here is focus on the energy consumption of the HVAC room and working on occupancy-based ventilation. So with all of this, the National Society, the American Society of Anesthesiologists, which is our national body, in October of 2024, endorsed that piped nitrous should be deactivated. And this is a huge statement because this affirms that the National Society in the US and globally many other societies have done this, really support deactivating it to mitigate the pollution and the impacts to human health from nitrous oxide. So with that, I want to introduce our panelists here, and some of them, like Dr. Brian Cheesebro, need no introduction at all. But I am thrilled to introduce my panelist here, and Dr. Brian Cheeseborough will speak first, and he's our clinician. He's an anesthesiologist right now and the medical director for environmental stewardship at Providence. And as many of you know, that Providence expands across 7 states and has about 52 different health systems there. He's also currently a faculty at OHSU, Oregon Health Sciences University. Graduated from Johns Hopkins University and was a resident here at University of California, San Francisco. Dr. Cheeseborough also serves as the vice chair, as I was mentioning, of the American Society of Anesthesiologists Committee on Environmental Health. In addition, he sits as the board of director for Oregon Business for Climate. And Dr. Brian Cheeseborough is an avid outdoors person, a huge climber, a huge skier. So we're very grateful that he's here on this panel to share his expertise. Along with him from the Providence Health Systems, we have Andy Mason, who leads the facility engineering department across 4 Providence hospitals. With 20 years of experience in healthcare facility management, and with especially a focus on electrical system safety, we're absolutely thrilled to have Andy with us here today, as he really has brought facilities and clinical care to decrease emissions of healthcare greenhouse gases. From UCSF Health, I'm really thrilled to have Alan and Chris both here. Alan is the Associate Facilities Director at UCSF Health Medical Center at the Parnassus Heights campus. And I've worked with him very closely as he was responsible in helping us develop our strategies and helping us navigate our deactivation process here. He's also responsible for a lot of the maintenance protocols, policies, and procedures for the medical center enterprise. Alan has his master's degrees in confirmation information systems, which was extremely valuable to us as we were navigating this process. Chris is here, and Chris is a senior engineer at UCSF Health Facilities, and very crucial because Chris also is involved in Joint Commission and regulatory programs, in addition to sort of fire safety and emergency and management of medical gases. Lastly, we also have from UC Davis, Albert Wong, who is the Director for Environmental Health and Safety. And as you hear our panelists, you will see that different systems have taken different approaches. And while at UCSF Health and Providence, it was led by a facilities director at UC Davis, Albert and his team at EH&S led this deactivation. So our goal today is to share with all the attendees that they're not one size fits all, but there are many different ways and nuances in which different systems have approached it. So the 2 years that we've been on this journey and some of the questions that Dr. Cheeseborough and the Providence Health Systems have had and we've had is we've tried to compile that in a panel discussion. And then after that, we're going to have an open dialogue with our panelists. And then we will take questions from the chat. So please keep your questions ready and use the Q&A feature to also put your resources, your suggestions, and all the questions that you might have for our panelists here. But for now, the panelists are also going to focus on within their facility, how did they really start this journey? And what were some of the timelines that were involved? And you will see that as more health systems sort of embark on it, the timeline is narrower, right? There's different team members, some of which were very crucial, and different health systems have taken different approaches on who the team members have to be. And so they will share that. And where was the oversight? Was it clinician-led? Was it a mandate from the health system? How they've sort of got about with their implementation processes, and they'll share that. But most importantly, some of the barriers that they experienced it. And all the health systems here have deactivated their pipe nitrous system. So what has the feedback been afterwards? And some of the benefits that they've seen post-implementation. So with that, I will pass it on to our next speaker, Dr. Brian Cheeseborough.
Thank you, Seema. I'm going to share. Okay. Thanks for the invitation to be here. I really wanted to provide kind of an overview of the whole process before we start talking about specific barriers and variability between different hospitals and approaches by different teams. I think it'll be helpful to kind of ground in kind of what this whole initiative looks like. So, and I also wanted just to get out in the front, provide access to these two resource documents, which are free, available at the websites there on the bottom left. I think they both complement each other. The one on the left is a bit more narrative, goes a lot into the why and building engagement within your hospital systems. The resource on the right is very action oriented with checklists and tasks and whatnot. I think if you're interested in embarking on this journey, and I hope that you all are, please use these resources. In terms of the why, there are a lot of good reasons to do this, which we aren't really going to focus on today as much. Safety, efficiency, patient-centeredness, environmental cost reduction, obviously, financial cost reduction. Another issue of value that needs to be considered is regulatory compliance, and are we allowed to do this? And I think there are two key take-homes related to compliance that are important to ground yourself and your teams with. One is there is no requirement for centrally supplied nitrous oxide. The FGI guidelines for the design and construction of hospitals, the version varies depending on what state you're in, but all of the versions of the FGI guidelines, none of them call for or mandate the existence of centrally supplied nitrous. So that's a good thing to keep in mind. Another important thing to keep in mind is that there are rules guiding the management of medical gas cylinders and central supply systems as well. These rules are housed within the NFPA 99 National Fire Protection Association Healthcare Facilities Code Handbook. I'm showing the version from 2012, which is important because that's the one that CMS has adopted as their standard. So while there have been subsequent updates and revisions to NFPA 99, the one that CMS holds as their source of truth is 2012. So how do you do this? How do you implement this project to shift essentially from the systems that we see in the bottom right to the portable systems that you see right above? And I encourage people to think of this as occurring in three phases. The first phase is assessing your current systems. Where are you starting from? Understanding your clinical use, understanding how much your facility is consuming per year, and then assessing your infrastructure. What systems, what hardware essentially do you have currently in place? That will really give you a sense of how complicated or potentially what financial costs may be borne by this project. The next phase is working to establish a reliable, effective, portable supply system, thinking through issues related to storage, handling and exchange of the cylinders, clinical use, how are the clinicians going to actually use these smaller cylinders? And then only when that portable system is in place and has been tested, do you move on to the final phase of deactivating the central supply system. I encourage people to work through that progressively, disconnecting first as a kind of stress test of the portable system before you move to depressurization and subsequent deactivation. So we'll walk through these fairly quickly, highlighting some common questions that come up in each of the phases. So we'll start with assessing your current system. One of the first questions that we're often faced with is, how bad is this really? How significant of a leak is this really? And I think that's where comparing the clinical use to the central system overall consumption can be helpful to build engagement, get everybody on board. The figure on the right is from the paper that Dr. Gandhi mentioned earlier. It's a combination of hospitals from Providence and UCSF. Each of those bars is an individual hospital. The blue section of the bars, that is the quantity per year of nitrous that's leaking from each of those facilities. The little gray tips on the bars, that's the quantity that's being used clinically. So you can see most of that figure is blue, most of that figure is waste. The median waste percentage that we found amongst all of these hospitals was 91%. Gathering these data generally comes from two sources. The clinical use data is often found within your electronic medical record. You want to try to find total liters of nitrous administered. If you don't have access to an EMR, or if you don't have an anesthesia machine with an electronic flow meter, it's a good idea to try to estimate your clinical consumption, try to figure out how many cases you're doing, how many are actually using nitrous for what duration of time and at what flow rate. This becomes also more relevant in non-anesthesia clinical locations such as dental clinics, labor and delivery, the ICU, the emergency department. You compare that against the central system consumption, which we get from procurement records, really honing in on data that is best acquired from your medical gas vendors directly, really looking at the number of cylinders containing more than 50 pounds of nitrous. Those are the ones that are attached to the central system. There are other cylinders containing nitrous that are used throughout the hospital. You don't really want to include those in this assessment of central system efficiency because they're not used in the central system. All right. Another very common assessment question is, well, what clinical services are going to be impacted by this transition? And we found that the best way to answer that question is to figure out where are all the clinical access points to the central supply system. Asking our facilities colleagues to provide a nitrous oxide wall outlet inventory lets you know exactly every room location where a clinician could potentially access centrally supplied nitrous. The majority of those will be in operating rooms or procedural medicine suites, but we do find them in labor and delivery, dental clinics, emergency rooms, and even intensive care units at times. The team members needed to implement the project, I would say the required team members are representative or a champion from the anesthesiology department, as well as facilities. An OR director, anesthesia technicians are critical, really helps to have a project manager. And then more of an as needed, and we'll hear from other panelists about the role for clinical engineers, supply chain, safety managers, specific unit managers outside of the OR, and hospital leadership. This is an important question that you want to try to get your hands around early. How complicated is this going to be for us? And that's where you start assessing your infrastructure. What do we have to work with? What's our starting point here? In terms of establishing the portable systems, understanding where your current storage locations are, and what kind of storage capacity each room has. That's very important, which we'll talk about later, I'm sure. Understanding what clinical delivery units currently exist in the hospital. What type of anesthesia machines do you have? Do you have portable nitrous delivery units for sedation or for use in a dental clinic? Are they compatible with e-cylinders? Do you already have e-cylinders? Are you going to need to retrofit any of these machines? These are important questions to ask and answer early in terms of planning for resource and action items later on. Moving to deactivating, I would say the depressurization step is really important. That's the step that you really want to try to get to as quickly as you can and is reasonable, because that's when you're addressing your leak. When you shut that main central valve, that's when you depressurize, that's when the leak stops, essentially. Understanding where your low pressure alarms are throughout the hospital. I know Andy will talk about this a bit more. Really critical to know where all those alarms are, know how to turn them off. And then the final step of deactivation, know what components are where, so that you can deactivate appropriately. Moving to the establishing the portable supply system. How are we going to store all these things? Again, confirm the location and logistics of the storage room. NFPA 99 has different kind of capacity classifications. It's important to understand what room has what capacity so that you can figure out how much room you have to work with. How many e-cylinders are we going to need? This is a very, very common question, so that you can determine, well, how many do we need to store? How many do we need to buy? What's our par level that we need to maintain going forward? This is another reason why it's important to do the best you can to quantify your clinical use so that you can match it to the number of e-cylinders that you need, keeping in mind that every e-cylinder holds just shy of 1,600 liters of nitrous. You can see in the figure on the lower right there, that's looking at annual consumption by clinical location in one of our Providence hospitals. And you can see, in OR3 there in the middle, we project that they were going to need 9 e-cylinders of nitrous for a year, whereas in, OR5, they're only going to need 3. When we first did this assessment, we were all kind of biting our nails, hoping that this would bear out and be accurate. Having done this now at 50 plus hospitals, I can tell you that this is quite robust and valid. I jumped ahead. Moving into handling exchange, how should they be exchanged? Assigning this body of work to team members is most commonly with anesthesia technicians, making sure that they understand the use protocol of keeping the valve closed when the cylinders aren't in use. That prevents another source of small but can be significant leak. And then making sure that they have a competency program, so that they're trained appropriately, and so that this process is safe. Making sure that the e-cylinders are compatible with the delivery units. This can be variable. The images there on the right. Some of our anesthesia machines come with a yoke, an attachment yoke for e-cylinders already. Those are easy. You just attach one on there. The machines in the figure in the image on the far right, those can require a retrofit, which can represent an expense for your hospital to get that done. And it's important to get a sense of that early on. The exchange trigger, when do you exchange for a new e-cylinder? That's something that you and your team in collaboration with your clinicians needs to figure out. That could either be when your anesthesia machine fires a low pressure alarm from the cylinder, or it could be running the cylinders completely to empty. Those are some of the options. You'll have to, again, through your assessment of your infrastructure, understand if your machine has an alarm. Is that an appropriate trigger for you? Are you comfortable with that? Make sure your clinicians are educated as well. Deactivation, I'm going to go through pretty quickly because there are several people a lot smarter than I am to talk about this. Can we do a trial period to make sure everything is okay? Yes, and I would encourage you to do that. It's as easy as disconnecting the wall hoses or the drop hoses from the wall outlets, and testing it. Define the trial period, come back around, make sure everyone's comfortable and confident before you proceed to the next step, which is depressurization. Again, I mentioned this before. Before you shut that valve off, in order to save yourself a lot of headache and heartache, you want to confirm that all the central system low pressure alarms have been deactivated. See Andy smiling because he lived this experience. And then finally, deactivation. This is a common question. Do we have to physically remove all of the central supply system components? And there's confusion around this. Some people, we've run into some people who say, well, we have to get rid of all the pipes. We have to get rid of everything. And that's not, I feel like that stems from a well-intentioned but slightly misunderstood interpretation of NFPA 101, which is a life safety code. And I'd ask you to focus on the second paragraph. It's not intended that the entire system be removed. Instead, components should be removed to reduce the likelihood of relying on inoperable systems or features, which moves us down to one of the important steps of deactivation, which is making sure that it's very clear in labeling and deactivation that for the clinical end user that system is not going to work. Regulatory approval, we can probably talk about a bit more in the Q&A. This is highly variable depending on the state you're in. Some states don't require a submission or much approval at all. Others want to see a very detailed project proposal about how and why you're going to do this. I have some listed suggested elements of a proposal that I have there, which you can refer to later. I also provided some example tables to help you keep yourself and the team organized. If you'd like copies of any of this, feel free to reach out to me at any point. The take-home message is this is absolutely possible. In most cases, the labor required is minimal. The costs required are minimal in most cases. And I would say this is largely a people project that requires education, engagement, careful action planning, and accountability to make sure that it gets all the way across the line. In terms of results, here is a similar figure showing just Providence hospitals. This time, every bar is a different hospital. Again, the blue is the volume of nitrous that's been lost to leak. We initially started with about 7 hospitals that were kind of our early adopters, our test kitchens where we were figuring this out. We subsequently launched a toolkit and with widespread accountability to get the work done. That was launched in March of 2024, and since then, the grayed out bars have been deactivated. So this can be done. It can be done at scale, and it can be done pretty quickly if you're motivated. With that, I will leave my email address. Again, if you have questions or want to reach out for any of the resources that I presented there, please don't hesitate to do so. With that, I will stop and hand it over, I believe, to Andy.
Thanks, Brian. Let me go ahead and share my screen. I think you're still sharing, Brian. Right. Thanks, everybody. I'm Andy Mason. I'm a director of facilities with Providence Health, covering 4 of our 8 acute care ministries in Oregon. So the first of our systems be deactivated in Oregon was at, or we started working with St. Vincent Hospital, which is our largest facility in Oregon, in 2021, early 2021, when Dr. Cheeseborough first approached me about where is all this nitrous that we're buying going, because it's not going to our patients. We went through a number of iterations and trials of various things before coming around to, hey, let's just turn it off near the end of 2021. So that was about a 10-month process. In that meantime, we actually realized how straightforward the process actually could be. And St. Vincent was actually leapfrogged by one of our smaller hospitals. So by the end of 21, we actually had 2 hospitals in the process of being shut off. And by late 2024, we had actually done all 8.
Andy, I'm sorry to interrupt. You might need to share your screen again.
Okay.
We don't see it yet.
Stop slideshow. And try that again.
Oh, perfect. We see it.
Is that better? Okay. Let me That's better. Okay. Apologize. Zoom is not a platform I'm particularly familiar with. And at this point, we, as Dr. Cheeseborough mentioned, we've done a fairly significant number over the 52 hospitals in our entire health system. I'm pretty proud of that. Working through the process, because we didn't really have a background in getting from pipe to distributed nitrous oxide, our significant concern was the amount we were using in pediatric surgery, because that was by far the highest use in the facility. So when we first converted to distributed supply, we left the pipe system on in pediatrics, but it was very quickly realized that was not necessary. And literally within a few weeks, we had converted the entire facility to local supply. The timeline did vary quite a bit between facilities. As I mentioned, it took about 10 months to figure it out and get it done at St. Vincent. One of our smaller facilities out on the coast took less than a month from the first meeting to the last valve being closed. Some of our facilities that actually required a bit of a investment in cradles and regulators on the anesthesia machines took a fair bit more time, and it actually wasn't until we got system-wide pressure to get this done across Providence that the local administration finally said, yeah, it's time and we need to get it done. I can't say enough about how Dr. Cheeseborough is really I think the face of this effort nationwide. And he definitely was the instigator in Providence. He was essentially the project manager, I would say, for St. Vincent, where we did this the first time. And once leadership really saw the value after we had done a number of hospitals, then it was mandated from the system level and system level leadership, which really lit a fire and got it going. And at every facility, I think Dr. Cheeseborough's list of important team members was excellent. We had to have clinical representation, the OR director, the anesthesiology group. Facilities is crucial. You're not going to turn off their system without their participation. And you really have to have administration. Usually the COO at any given facility is involved in this. And in a few cases, like where we needed to add the cradles and regulators to anesthesia machines, clinical engineering was involved with that. And at each facility where we did this, the actual oversight of the process was generally a joint venture between facilities and clinical staff, because there really are two parallel pathways. Establishing your portable supply is really more of a clinical effort, and deactivating the central supply is more of a facilities effort. So the process really needs to begin with a risk assessment. Gather the team, whoever you need at a given facility, and do the risk assessment to determine, okay, how do we get to a distributed supply and shutting off of our central supply. Definitely use the available tools that are out there. The toolkits that Dr. Cheeseborough showed have been used widely and are very effective. You need to engage your state level AHJ fairly early on to determine what the requirements are going to be, because they really do vary extremely widely from state to state. Even in the Providence system, we've seen huge variability. But it turns out I was extremely fortunate in Oregon that we had a very willing health department that saw the value in this and never asked us to remove the entire system or put in a change of use or anything like that, which is the case in a lot of our other areas. Now, switching to a portable supply, as I said, is a kind of a parallel effort to deactivating the central supply. And it is a good idea to establish your portable supply and just run with it for a little while to make sure clinical staff is completely okay with it. While you're establishing that central or distributed supply, facilities can be doing their legwork to determine how do you disable your local and central med gas alarms. That's probably one of the biggest hurdles. I can't stress enough, start by finding the manual for each of your alarm panels. That oftentimes was all you take. Just simply going through the instructions will often tell you step by step how to disable those alarms. We did some of our smaller facilities that don't have a large facilities engineering team did just bring in a vendor. It was relatively low cost and pretty simple to have them just point them at it. And they went through, blanked off outlets, disabled alarm channels, and shut off the central supply. It is probably most important to be ready to have a plan and be ready to label the system as out of service as step one, because it really is important that no one in the field, no clinician think it's available when it isn't. So labeling is definitely step one. Disable your field alarms and then shut your valves. We actually had an issue with St. Vincent, the first major hospital we shut off, where we didn't do our research quite well enough and thought we had some of the alarm channels disabled when they weren't. And as the system bled down after being shut off, some of the alarms started going off for no apparent reason. So definitely figure it out for each type of alarm, especially in some of your older facilities where you might have had a lot of growth over time and you've got, I think we had 5 different styles of alarm that we had to figure out. As to barriers, I think the biggest one was, especially if there was any financial outlay involved, getting administration to understand why we needed to fix something that was working, and really laying out the case for why this work needs to be done, the climate impact of the waste of this gas, and actually figuring out the right way to disable the alarms was a bit of a challenge. And fortunately, a lot of our facilities have a quality vendor that they work with that was able to help get that done. And after deactivation, really this has been seamless. I don't personally know of any issues that have cropped up at any of our facilities post deactivation. It just one day they switched to the other process and it has been just a non-issue, honestly. The remaining nitrous cylinders were returned to the vendor. We did our best to return empty cylinders. And one really cool statistic from this, we always knew that it wasn't a huge value proposition from a financial standpoint. I think we're saving around $20,000 a year in Oregon by converting to a distributed supply and using the e-cylinders. So not a significant savings there, but we're saving approximately 1,575 tons equivalent carbon emissions per year in the state of Oregon, which is actually about the same as if we had converted 2 central plants at some of our smaller facilities to electricity, and that doesn't account for the ongoing cost of buying clean energy to feed those central plants. Those projects would cost in the millions of dollars. So this is an incredibly inexpensive way to make a huge impact to our carbon emissions. And there's my email. I'm always happy to answer any questions or consult directly with anyone who has a question on how to get from point A to point B.
Okay, I think it's going to be Alan and Chris next. You want to share your slide deck and take it away?
Yeah, will do. Thank you very much, Seema. Give me a second here. Okay, great. Yes, I'm Alan Latwinick. I'm the Associate Facilities Director at UCSF at Parnassus Heights. And we have Chris Schroer here, who's our Senior Chief Engineer, who works at all sites at UCSF here in San Francisco, which are Mount Zion, Mission Bay, Parnassus Heights, and now St. Mary's and St. Francis hospitals. So UCSF recently transitioned 49 ORs and across various sites, as mentioned, Parnassus Heights, Mount Zion. We also did 4 outpatient surgery centers at Parnassus Heights at our ACC building, in addition to 5 ORs down at Mission Bay at our Orthopedic Institute. Coming soon, Mission Bay, our medical center, will be separating the piping systems at our dental clinics, while the pediatric surgery and labor and delivery areas get deactivated. Dr. Gandhi, Medical Director of Sustainability, initiated this project at UCSF, and we partnered with her. The timeline for conversions began in 2022. And we deactivated from 2023 through June of 2023. Our team members included Chris Schroer, who's our Senior Chief Engineer, myself, Jorik de Guzman, who's the Head of Health Facilities here at UCSF. And we also had Sheila Atram, our COO, as our executive sponsor. So the deactivation process. So our team validated all our as-built drawings at each location with our certified med gas vendor, CYA. I see Carson's here today. Welcome, Carson. With no risk identified, health facilities, we developed an MOP for deactivation, including minimal to no operational impact to our hospital operations. We collaborated with all our stakeholders and went through the MOP for implementation. Once we had agreement, we executed our MOP, or method of procedure. We then, after deactivation, updated, which is very important, all our documentation to reflect these changes, in addition to covering our CMMS system. As mentioned, our med gas vendor CYA assisted in this deactivation. And then we also coordinated with our stakeholders to minimize impacts to patient care, which is critical. Post deactivation, Chris, you can take it away from there.
Thank you, Alan. So the feedback was positive. I think a couple of things was once the users, clients, staff realize what it does to the environment, and they felt, there was a lot of good there. Also, for the university, it helps us show our commitment to climate sustainability. The facility still has nitrous cylinders, but at a reduced amount. So we were able to get rid of, excuse me, the H-type cylinders on the bulk systems, which then allowed us to have a little bit more storage for everything else. There was some cost savings, 1.2 million. That was for the projects. There was 2 projects in the pipeline at Mission. One was at Mission Bay and one was at Parnassus Heights that we were able to eliminate that out of the projects. And then for on the facilities end, we were able to save because we do annual certifications, repairs, we purchase the product. So for us as a facility, it does help us in our maintenance and how we do our business. Next slide, please, Ellen. The standard now says that the responsible facility authority role shall be the person responsible for implementing the NFPA 99 gas requirements within the facility. So again, Alan had mentioned our med gas provider, not provider, but our med gas service person, CYA. They helped us assess the system and helped us with code references that would help us document what we were doing. And this is just some of the individuals designated as responsible facility authorities: medical gas installer, inspector, verifier, gas maintenance personnel. Instead of attending one of these credentials, the individual can also take a can qualify by completing an educational program equivalent or superior to the ASSE program. Let me see. Yeah, so facility had partnered with our medical gas authority to ensure that there was code to support the decommissioning. And so we looked at NFPA 99 and 55. NFPA 99 21 edition does introduce several small changes and clarifications. 99 focuses on the importance of the role of responsible facility authority as the on-site, as the authority for medical gas systems, right? It also explains the provisions, additional direction for decommissioning clinical spaces, clarifies requirements to align with NFPA 55. There are some things in there on the ORs and things like that. Yeah, and then the code reference that support this was in NFPA 99, like one of the other presenters had mentioned, and all changes in status of all components of the NO2 system, shall be decommissioned. And so that's the stuff, the people that inspect us, the regulatory people, it's like, how did you get there? And so we really want to go to the code to support how we operate, right? Because let's just say they come in and survey us and we just say, oh yeah, we did it. That isn't how we operate. We operate in a way that we can document and show that we have decommissioned assets within our CMS system, and that we have code references to show within our program that we have done the right things for our organization. Next slide, Alan. That might be the last slide, actually.
Yeah. Thank you, Chris, for taking us to the end. So if you have any questions to what Chris and I presented today, feel free to reach out to us. Thank you.
All right, Albert will take it away from UC Davis.
Thank you.
And to all the attendees, please feel free to use the Q&A feature while Albert pulls up the slides, and add your questions to Q&A, and we'll have sort of a very healthy discussion after.
Hi, my name is Albert Huang. I'm with UC Davis Health, and thank you for having me today. And our site, we deactivated our pipe nitrous system in our same-day surgery center and also in our inpatient adult operating rooms, in addition to children's surgery ORs. So a total of 51, including a number of procedure rooms. And it was a team of physicians and other stakeholders who initiated the project with the support of leadership from the operation In the timeline, we started about the timeline. We started in late 2022 because it was one of the sustainability goal or objective for the UC Davis health systems. So it was in our interest to investigate and pursue the project. And the completion was June 2023. We also used CYA, the medical gas vendor service, to deactivate our system in June 2023. And the key team members involved, including the facility staff, clinical engineering, licensure accreditation, supply chain, operational analytics, and environmental health and safety. So it's very similar to other speakers who presented just now. So it's very similar that it takes a team of different background of different departments and discipline to support this effort. And also our amazing sustainability director also was leading the project and provided oversight. And in terms of implementation, from our experience, I would suggest that starting with same-day surgery, because that's smaller, because same-day surgery, usually the number of ORs are smaller than the inpatient adult surgery OR or children OR. So we started, one technique, one approach is to start small at a standalone same-day outpatient OR, same-day surgery. That was found to be a good way to start the project. And one of the barriers that we had encountered was the concern from stakeholders about the potential disruption to patient care, because we want to make sure that clinicians or providers are not trying to use the outlet when it's no longer available. So it takes a lot of communications, and we also send out communications to all providers. The leader of the anesthesiology department sent out the communication to all the providers to alert the plan well in advance, so that there's no surprises, and also to get buy-ins from everyone in case if there's any questions. So those communication in advance, and also discussion between the project team and the stakeholders were very helpful and important. So as a result, the deactivation was seamless. There was no surprises or disruption reported as a result. And we have experienced similar reduction as that's reported by Dr. Cheesebro. So we have seen around 90% or more reduction in the amount of nitrous oxide that we purchase. So for our side, that results in approximately 35,000 cubic feet of nitrous oxide gas purchased or eliminated, or 537 tons, equivalent tons of CO2 emission. So the direct cost savings of not purchasing the nitrous oxide gas cylinder was $9,000 per year. And there are additional savings of emission reduction and so on. And also there's I can imagine there's maintenance costs to the nitrous oxide pipe system which would be reduced because of the deactivation. And lastly, the two new facilities that we are building at our site, we are not having nitrous oxide pipe system design or built in. So in other words, the new sites will not have this. And thank you. And if you have any questions, feel free to reach out. Thank you.
Thank you to all the panelists. This was such an informative session, and my only regret is that where was this when we were embarking on our journey and we needed all the support. So thank you all for at least, people going forward, other health systems embarking or ongoing will really benefit from this. So I just had a few questions, and I think I wanted to also highlight, which I was hearing over and over again, is that post-implementation for all the health systems here, it seems like it was very seamless, right? With adequate preparation of involving clinicians, timing it, and really, as Dr. Cheeseborough said, communicating. It's a people effort. So getting all the multiple stakeholders on board, it seems like it's been very seamless and well accepted. And also what I'm hearing is that a lot of the ongoing, the systems that are doing it, the newer hospitals will not have pipe nitrous, and we definitely know that that's true for UCSF Health, Providence, and also it seems hearing from Albert for UC Davis. So that's all great news. And I've heard you speak before, Dr. Cheeseborough, and I'm going to sort of direct this question to you, and I know Chris and Alan can chime in afterwards, is I've heard you speak before, and we've talked a lot about sort of the regulatory concerns that different health systems have based on the different states. So can you please talk to our audience, and there's a question in the audience about how do you find out what the regulatory requirements for your particular state are?
Sure. I'll go first, and then I'll defer to our facilities folks. In terms of figuring out whether you're in a state that requires a formal proposal, I think it comes down to figuring out who your authority having jurisdiction is. And that's I've learned a lot of new acronyms in the course of this project, and AHJ is the authority having jurisdiction. That might be your state's Department of Health. That might be your local fire marshal. That might be some other building inspector that I can't think of. The first person I would reach to when you're thinking about this is to your facilities team, and figure out who on your facilities team is responsible for your medical gas supply systems. That person or persons should know who your authority having jurisdiction is. Once you know who that entity is, then you can ask them. Andy can speak to his experience in Oregon, reaching to the Oregon Department of Health and how that went. But the first and most important step is figuring out who your AHJ is and reaching out to them directly. It's going to vary dramatically. And I'll just kick it to Andy or Chris or Alan.
I think all of the above of what you said, right? And then if you don't have authority of jurisdiction, you always can call probably your local medical gas provider, and they can help you because they are the experts, in my opinion, of the system. Even though, facilities, we maintain them, we touch them, over time you learn a lot about them. But I really think with providers, you're really led in the right direction, especially if they're experienced. We do have an experienced provider, and he does go nationally, and it does help just to make sure we're hitting, you're doing the right things. It's always good to have some more guidance. I think the more people you involve that understand it, the better results you'll have.
Yeah, I think it's important to understand that we've been talking about this for years, so it seems like old information, but a lot of times the Department of Health or whoever is the AHJ, this is new to them. And they think of med gas systems as Category 1 systems in total. Whereas we know that a nitrous oxide system is probably a Category 3 or Category 4 system, where its failure basically doesn't pose any hazard or even discomfort to the patient or the staff. But because it is parallel to highly critical systems, it's usually treated in the same way. And when the AHJ hears, I'm going to turn this off, they freak out. So it's really important to do your homework before reaching out to them and be able to very clearly articulate, I have evaluated how many E-cylinders I'm going to bring into the facility. I know I am not going to exceed the 3,000 cubic feet per smoke compartment per NFPA 99, et cetera, et cetera. If you can speak to the concerns that start popping up at the top of their head when you start having this conversation, you'll have a much better experience than if you just say, hey, I'm going to turn off my nitrous oxide system. What do you think?
Thank you. And I think there's a question in the chat, and we definitely had this experience across the UC system. So I want to hear from all of you, sort of the technical leads here, is how did the health system decide, right? We know some health systems have just done the process, the facility leads have led it, and then you've had it certified. While with others, for UCSF Health, you heard that we had a vendor, like CYA was our vendor in that case. So I just want to hear from our panelists on how was that decision made. Andy, you want to start with sort of how Providence has approached this, and then we can let the UC lead start.
It really does depend on the size and expertise of your facilities departments. Some of our smaller hospitals, they have very small facilities teams. They don't necessarily understand these systems as well because they don't have a single person dedicated to this system, because it's a small enough system. It's just peripheral. It's one of the things they do a whole bunch, and they don't do a whole bunch, and they bring a vendor in to do a lot of their annual testing and annual certification. They might not even be 90/30 certified to do maintenance on a medical gas system. So in those cases, often we did bring a vendor in. In others, in fact, at our two largest hospitals, because we do have an engineer in the facilities department whose job is to maintain the medical gas system, they dove in head first. And they're digging through the manuals and figuring out how to disable the alarm channels and et cetera. So just because we had a larger team to pull from, a deeper well of experience there, that actually made that go a little smoother. But yeah, our vendors were universally happy to help when we reached out to them. So don't feel like that's an impediment if you don't have somebody on the team in-house that's able to do all of that work.
Chris and Albert, let's hear how UC systems have approached this.
Sorry. Yeah, go ahead, and then Chris and I can follow up.
Oh, sure. For our site, CYA, the vendor CYA happens to be the same vendor who maintains our medical gas system, including the manifold system. So that gave us the advantage because the vendor is familiar with our system. So it takes the risk of disruption out of the picture, at least most part. So that helps a lot. Thank you.
Yeah, and then I'll echo what what Albert mentioned. I mean, at UCSF, we partnered with CYA for countless years. We have them involved in currently we're going through a new hospital design and build. They're integral to that. All the areas that we touched upon, they were in some way, shape, or form, involved with initial designs, in addition to ongoing maintenance, helping us out. We do have staff that they're very familiar with these systems and maintain them on a day-to-day operational basis. But for an undertaking like this, we always partner with Karsten Lund and CYA, just to make sure that we're doing things correctly. Also, we have a large design and construction group, and we interact with HCI on a regular basis. So we do have a mechanism to run whatever it is that we're going to be doing through the authority having jurisdiction. We partner with them. So it's these are just all folks that we work with on a I wouldn't say a day-to-day basis, but quite frequently, and partner with them. And I think you get a better solution when you have various experts that you can collaborate with. And Chris, feel free to chime in.
No, I think that again, I think we all covered it. I don't want to overstate it.
Yep. Thank you, Chris.
I wanted to sort of highlight two questions that probably Dr. Chesebro and me and many on this panel have faced over and over again. And one is, what happens with the existing cylinders once you deactivate? Can you just leave them connected to the manifold? Do they have to be vented? So I wanted to sort of hear from the panel on what they have done at their health systems.
I think so dealing with that residual volume, once you depressurize your system and you're left with partially full supply cylinders, given the quantities that are relevant at most hospitals, I think the most common course of action is to return those partially full cylinders to the vendor. I mean, they're going to reuse the cylinders. They will vent the nitrous when it comes back to their facility. They have to vent it because they're trying to adhere to a chain of custody for a medical gas that's administered to patients. They're not going to top off a cylinder that they haven't had custody over and then resell it to somebody else. So in terms of smaller volumes, you just kind of have to eat that venting and accept it as the cost an environmental cost of doing the deactivation. There are a handful of facilities that we've come across nationally that have enormous exterior tanks. Massachusetts General in Boston, Maine Medical in Portland, Maine, they have these huge exterior containers that hold tens of thousands of pounds of nitrous. And that's a different game. You don't necessarily just want to vent all of that. They've found in New England a vendor who has agreed to come in and kind of siphon off or repackage that kind of volume into smaller portable tanks to be taken away. I'm not sure exactly what they're going to do with it, to be totally honest with you. I think that the scale of dealing with 10,000 pounds of residual nitrous makes it worth it for them to come and do that. They're not going to do that for 50-pound cylinders. So you're just going to have to, I think you're just going to have to send them back to the vendor and eat it, and just be happy that you're not going to waste another 4 and another 4 and another 4 that are venting through your hospital right now.
Yeah, I would also mention that if you have cryo tanks rather than pressurized tanks, they're going to vent anyway. Over time, they will simply empty themselves into your tank room as they evaporate.
Thank you, Andy, and I'll let Dr. Chesebro briefly touch about this because it's a question. Is the rate of leakage, and I think there's a question about comparing cryogenic versus etch, if you can briefly talk about it.
Sure. I mean, certainly if you walk into your central medical gas supply room and you see cryogenic containers, you have a leak. As Andy said, they leak by design. It doesn't necessarily mean that that's your biggest source of leak. So in looking at all the hospitals in the Providence system, when we started, we had, I think, 4 or 5 that had cryogenic containers. The rest had compressed gas cylinders. But the hospital that had the highest volume and degree of leak was not a cryogenically supplied hospital. It was a compressed gas hospital. So while the supply container can be a source of leak, every component downstream between the cylinder, between the container and the patient has the potential to leak. It doesn't mean that every component is leaking in every hospital, but every component has the potential to leak. And the sum total of those delivery system leaks could easily exceed that of an inherent cryogenic container leak. So you know it's a problem if you see them, but it may or may not be your biggest source of problem.
A couple of questions about the value, the cost savings. And we've talked about sort of the CO2 impact and the environmental impact, but there are a couple of questions about sort of the dollar savings. Now, we know inherently that nitrous oxide is not a very expensive gas compared to the other anesthesia gases that we use on a regular basis. And I think across the health systems, we found that, you know, the cost savings is not enormous. It's like 10, 20, depending on the size of your 10, 20,000, depending on the size of your institution. But the 1.2 million that we mentioned in the chat was about eliminating it from new construction because the copper pipes inherently are very expensive and the laying cost and the architectural cost with it. What also is being asked in one of the questions is, can we repurpose these pipes? So that's a question for the panel. Is there a way to repurpose these pipes and use it for any other use?
I'll give you a clinician's perspective, and I would ask, well, what gas would be necessary at that kind of volume, requiring that delivery system to the outlets that are currently deployed for nitrous oxide? And I can't really think of one, to be honest with you. Oxygen is already going there. Medical air is already going there. CO2 is already going there. I can't think of another gas that would be useful to supply in that through those pipes. So I personally can't think of a clinical reason why you would want to repurpose them, but I'd be happy to hear from others as well.
Yeah, I think I would just say, once you decommission the system, you have to recommission a system, and you would find out through that process if you could, what you could or could not do with that piping, because it does have to go through some formal process to put any kind of gas back into service. So I think that's where you would really find out once you were doing your investigating into what you were going to use.
Yeah, I would chime in that it would be challenging, just because what we found, I think everywhere, is that these systems are commissioned on day 1 and they're generally leak free, but by year 20, they're not. And we test, NFPA 99 requires you to test your ports every year. That's really the only thing that's required to be tested. And so it may be quite a challenge to repurpose that piping for another purpose without replacing every zone valve, every sensor port, every outlet. It would still be maybe less expensive than installing an entire new copper system, but it would still be a significant challenge to commission that system when you had it converted.
And the sort of the cliched statement is, every time we heard this statement, which I'm going to say now, is, if I had $1, then we'd all be retired now. And the statement is, we test our systems annually. There is no way that our system is leaking. Maybe the other health systems who are doing this don't test their systems annually. And I hear the nods from everyone on the screen. So I'll just say that one of the ways to get around it is to really match your procurement and utilization data if you have electronic health record systems. And we've done it across multiple hospitals and Dr. Cheeseborough has done the same. So that's the way. And again, it's the inherent nature of the gas. But I want others on this panel to really talk about this.
That was going to be my comment as well, Seema. I think, the testing a system, I think the first thing I would say is, well, how are you testing it exactly? Can you walk me through the process of your annual test of the system? Is it just testing the outlets annually, or are you hand-over-handing every pipe and every fixture every year? I would argue that it's likely the former, not so likely to be the latter. So understanding what they mean by we test it. Do they do a standing pressure test every year? I would listen more to that as well. But in the end, I think it speaks to the value of bringing the clinical use data and the facility consumption data together and say, okay, we'll explain this. I mean, that's what started us on this whole journey, is seeing this discrepancy and saying, what is going on? How can this be possible? And we scratched our heads too. I didn't believe it either. When we first ran the numbers, I did it, 100 different ways, 100 different times to convince myself that it was real too. And having done it now across Providence, the UC system has done it. Many other health systems in the US have done it. Australia, the UK, Singapore, France. This is an international finding. It's not a Providence finding. It's not a UCSF finding. Everybody is finding this. And I would put it back to the team that's skeptical and say, well, come up with an alternative hypothesis that makes sense. Because right now, based on everybody else's experience and the fact that this implementation of this project solves the problem, right? So it's not only that our assessment is slightly different and has identified this huge inefficiency, it's that running through this cycle and changing the system and doing another assessment, and you say, the problem that we found is now fixed, right? So really the owner should be kicked back to the person who is expressing skepticism and say, well, how do you explain all of this otherwise? That's what I would do in a nice way. But
I'm going to ask a question about, is nitrous available clinically, or have we eliminated it? And I think that to that I would say is that for multiple reasons. One is the providers, if they want nitrous, we've never made the clinical decision for them. It's always available. It's just the source was through a more sort of point of care portable system. So the outliers and the providers that feel they need it always have nitrous available. So yes, it is available in our system. And I think that Dr. Cheeseborough would probably say the same. So I'll move on to the next question is, at UCSF Health, why was dentistry eliminated? And the reason that is we're still working on educating our dental colleagues, identifying other portable systems for them. But in the meantime, because dentistry, pediatrics, labor and delivery are all connected at our health system, we're trying to delineate, differentiate, and stop the main health system. But dentistry is not the focus for this year, but it will be a focus future as we work on engaging the stakeholders in the School of Dentistry. A question I have for you, Dr. Cheeseborough, that is coming up over and over again is about e-cylinders in the anesthesia machines and alarm limits. Are there e-cylinders and alarm limits, and how have you sort of decided on those?
Sure, it depends on the make and model of your anesthesia machine, whether it will help you determine an exchange trigger. And so during that initial assessment of your infrastructure, that's one of the things that you should try to discover. What make and model machines are in what locations? Do they have a low pressure alarm for the nitrous e-cylinder yoke? And what pressure is it? What is it set to? So by way of an example, General Electric makes a very common anesthesia machine called the ISIS Care Station 2. It does have a low pressure alarm associated with the nitrous E cylinder. It fires at 381 PSI. Don't ask me why, that's what it is. So you know that that's when the clinician is going to get an alert that the cylinder has crossed this low pressure threshold. We looked at that and said, well, how much volume is left when the pressure in the cylinder is 380? It's about 100 liters of usable nitrous remain in that cylinder. So you take that information back to the clinicians when you educate them about this transition and say, these are the machines we have. You're going to see this alert at this pressure threshold. It means you have 100 liters left. Call the anesthesia tech. They'll bring in a new cylinder. You have time to make the exchange. It gets a little bit more tricky when you're dealing with anesthesia machines that don't have a low pressure alarm, as many do not. And then you have to have the clinicians be vigilant about watching the pressure gauge on the E cylinder. And as my dad used to say when I was learning to drive a tractor, a good pilot has to watch the gauges all the time, right? And you have to pay attention to all of your gauges in order for the tractor to work properly, or the anesthesia machine to work properly. So in that case, you would educate your clinicians to say, well, you need to keep an eye on the pressure gauge on the nitrous E cylinder and call for it appropriately. Some hospitals have chosen to just use it till the cylinders run empty. Others have set a threshold. It's up to you.
Thank you, Dr. Cheesebro. And working with your clinical technology team is huge and setting the limits. We're coming to the end of the webinar, and I really want to thank all my panelists again. And Kai and Michaela, the Office of the President. Also, in this series, we have a webinar on climate-ready healthcare, building resilience, and with collaborative toolkits on March 26th, which we will send out details for. And in this last minute, if there is any pearls of wisdoms that the panelists would like to share, you have a minute to do so.
Well, one thing that I want everybody to take away is your system leaks. Just accept it. If you're using cryo tanks, your system leaks a lot. So you'll save yourself a lot of headache if you just accept your system is inefficient.
I just want to thank the panel and thank the people that attended. Greatly appreciate it. I think there was a lot of good information provided here today. And I think I learned a couple of things myself from the panel. Thank you.
Thank you very much. Thank you, everyone, and have a good rest of the day. All the panelists are available. The webinar link will be provided, and so will a list of MCQs and toolkits that we're working on. So thank you very much, and stay tuned for the next webinar.
Thank you.
Thank you.
Thank you.